Okay, welcome everybody. Welcome to this webinar. I'd like to thank everybody for joining this presentation on updates to ASM accreditation. Just one quick note, the chat feature has been turned off, but you can post any of your questions during the webinar to the Q&A feature. That's going to be at the bottom. So with that said, I'd like to introduce Dr. Olson, ASM's president.
Hello, everyone. Thanks, Ray. I am Eric Olson. I am a pulmonary critical care and sleep specialist at Mayo Clinic in Rochester and have the privilege of being the Academy's president for this year. It's also my privilege to participate in today's webinar, which seeks to address the new model of AASM accreditation. AASM accreditation is one of the most important things that the Academy does. It's a marker of high standards. We think it's important for improving patient outcomes, enhancing the professional reputation of accredited centers, and facilitating insurance coverage. For its full impact and relevance, however, the ASM accreditation process needs to be fluid, and it requires periodic updating to remain consistent with changes in technology and updates in clinical practice. And practice models have definitely evolved and changed significantly in sleep medicine over the years. There are more complex arrangements, there's less dependence on physical infrastructure, and the new accreditation processes that we'll be discussing today really seek to accommodate this broader spectrum of practice models that we're seeing within sleep medicine, and thereby allow facilities to really tailor their accreditation to suit their specific practice model. And hopefully through doing that, we increase your efficiency, we increase your flexibility, and we increase the adaptability of the whole accreditation model. Now, the ASM has been accrediting facilities for nearly 50 years. And the changes we'll be discussing today have been years in the making. They have been shaped by input from many important stakeholders, Academy members, you as accredited programs, ASM senior staff, and the board of directors. And we're very excited about what we have to share today with an implementation goal of being the next calendar year, 2025. I'm really pleased to be joined by Ray and Miriam. Ray will review the timeline that has led us to this point and summarize the reasons for the accreditation changes. He will elaborate on some of the coming differences in the accreditation framework, that is the structure of the application process, and how those standards or requirements that must be met can be incorporated into this new framework. And this discussion of changes of the framework and the standards is going to be based on this concept of networks that describes how services are used and are interrelated. Ray will then review the anticipated benefits of these changes and some of the pricing details. Miriam will follow and will elaborate on important membership changes and how they align with the new accreditation framework. For some entities, you may not see a lot of changes. For others, the changes will be welcome. They'll simplify your compliance, they'll remove barriers, and they'll streamline your operations. And I'm really excited to hear this summary. And therefore, Ray and Miriam, I'm going to hand it back to you to take it from here.
Thank you very much, Dr. Olson, for that introduction. So absolutely, we're going to be talking about these updates for the new model of accreditation. And as we think through them, this is what we're going to talk about. So what are those changes? Why those changes are taking place? And as introduced, it's really broken down into two parts when we think about the accreditation aspect, the framework and the standards. So we're going to break those out into detail. And then Miriam, our membership manager, she's going to then talk about how membership is also going to be aligning with that of the new model of accreditation. So as we set the stage for that, I think it's important to indicate that we oftentimes make updates to our standards. We do this actually typically about every 2 to 3 years. And so this timeline helps represent that. And this is actually going back to 2004. And so you can see how periodically, about every 2 to 3 years, we are having these updates to our standards. And we do that so that we remain consistent with changes in technology, and we can remain consistent with updates in clinical practice. Now, every time there is an update, it always is getting reviewed by our accreditation committee. so which is made up of experts in the field, our members, and then those recommendations go to the board and is ultimately approved by the board. This slide helps represent the timeline for how long we have been working on this new model of accreditation. You can actually see we began development of this in 2018. And as indicated, we've had some notable events throughout that time period. So we had 2 public comment periods. We had a public comment period from our payers, and then we had a public comment period from our members and accredited programs, following which we were able to approve and announce the new model standards, which came out spring of 2024. And then what we're looking for in the future on the horizon, we have our transition of facility membership coming out October 1st. And then we have our new application coming out January 2025. And then the compliance period. So the compliance period will be from January 2025 to January 2026. So a year-long compliance period to become compliant to our accreditation standards for all of our accredited programs. So let's start talking about what those new model changes are. We're going to see during this presentation that really it is broken up into 2 main parts, accreditation and membership. So as indicated, Miriam, towards a later part of this presentation, will talk about how our membership is aligning with that of the new model. But from an accreditation perspective, and we'll cover this part first, it's really broken out into 2 aspects. The first being the standards for accreditation, and then the second being that framework. So from a standard perspective, it is affecting our sleep facility, ISP, and DME programs. And we'll get into detail about what those changes are and the benefits of them. And then from a framework perspective, what is changing is we are moving to what is considered a modular service-based accreditation. We're focusing on the services within a program. And so that would be the clinic where patient management is done, the lab where in-lab testing is done, home sleep apnea testing services, and DME. So within our current structure, we have program types, but within those program types, we have the specific services. And so we'll get into more detail about current structure compared to this new model, but that is the aspect of it where we're changing our framework to really focus on the services and the relationships between the services. And then the underlying theme here that we want to make sure that we address is that really in all that we're doing from an accreditation perspective and membership perspective, we're really aligning with that of our accreditation networks. And so we introduced that in July of 2021. And if we actually think about that key event timeline, we talked about the fact that we actually started development in 2018. And so when we introduced the networks, that is an early phase of kind of getting us to where we needed to be now. So from a network perspective, we are aligning with that, and we'll talk a little bit more about why that's important, even what a network is, and then the benefits of them. But why are we doing this? I think that's a good question to start with. And it's because practice models have evolved since 2016. And I'll specifically throw 2016 out there because 2016 was when we had the last significant change to our standards. So many might recall in 2016, our standards became patient-centric. So we added a whole new safety section. We added the patient rights section. Our quality assurance became to be process and outcome measures, right, for the patient, so focusing on the patient. And so since 2016, if we look at how the field of sleep medicine currently or the practices that are current compared to 2016, the models have significantly shifted. And so actually we've kind of outgrown what is our current model of accreditation. If we look at the trend of our accredited programs, this is what we're seeing. Larger hospitals, physician medical groups, complex health systems, that's what is more prevalent. But even with that said, smaller practices are leveraging technology to expand their reach too. And so that ultimately indicates to us, look, we do need to change our current model. And so that's what is occurring here in 2015. And it's going to be based upon the feedback that you guys have provided to us. And so we are doing this so that we can remain current with the current practices, but then we can also make sure that our sleep facilities and our accredited programs, that as they continue to evolve, that they are also going to be able to achieve success in ongoing evolution of practice models. And so our new framework provides that flexibility for us to be able to make sure that practice models can continue to evolve. And so this slide helps actually share some examples of some issues and some feedback that we've gotten throughout the years. The first one is that our standards actually don't really align with that of a network. And so yes, we introduced the networks in 2021, but if we just take, for example, quality assurance, right now, one of the feedback that we get pretty often is, look, I'm all part of the same health system. We use the same EMR. It's really difficult for us to provide data based upon location, right? And so in this new model, simply just by having standards that can be met by the network for the purposes of compliance begins to simplify compliance to that standard. And so that's one of the aspects that is being addressed here, is where we will now have standards that align with the networks that was introduced in 2021. The second is that right now we don't actually, we only focus on the lab services. So though we know within a sleep facility, they have to have patient management through the clinic, they have to conduct home sleep apnea testing. Both of those are fundamental mandatory standards. In an application, we actually don't identify where the clinic and HSAT services are being performed. And that can be a challenge as we think about this, as we move towards value-based payment models. We need to shift our focus beyond what is just testing and make sure that we're identifying all the services within a network and where those services are being done and the relationships between those services. And so we have some infographics to help represent that as well. And then the third one here is that when we think about networks and how they're continuing to grow, oftentimes what we're seeing now is either these networks are using multiple locations, or they may use a single location to conduct a service. We'll take the example of HSAT services, where a network might have one location in which they provide home sleep apnea testing out of, and they kind of consider that their hub for what is the network. Well, currently right now, because our framework is a bit linear, it requires that they have to subcontract with themselves. And some feedback I get is, well, why do I have to do that? Once again, I'm a part of the same health system. So why does this need to be done? So this is once again another example of an inherent issue with our current model and where we need to be more flexible in that. And so if we take kind of a step back here and we think about how we will be moving to a modular accreditation system where we're focusing on the services, how our standards are going to align with that of the network, these are the big three takeaways that are really benefits for our accredited programs. So our accredited programs are going to see streamlined operations when we think about that application experience, where they can kind of pick and choose the services that they need to make up their network, and where they can add or remove certain services without having to add an entire new accreditation program. But once again, it sets them up for success as we continue to see new practice models continuing to emerge as well. It's going to simplify compliance. So it's going by having standards that can be met by the network, thereby it ends up reducing and simplifying compliance for that network to be able to meet a specific standard. And then the last thing is, once again, we're removing barriers. So the standards were reviewed to make sure that we are up to date with current practices and technology. And another point to the remove barriers is the accreditation committee was, when we're looking at these standards, was specifically tasked with making sure that we're looking at the standards to remove barriers, not add burden. So collectively, all the standards were looked at with that kind of task, that principle in mind, so we can make sure that there's, unlike 2016 where we might have had additional sections, there's not really anything significant in terms of added to our standards, but actually a reduction in barriers. So a lot of exciting changes here, and really all to the betterment of our accredited programs. And this slide really just highlights that, because we go back to that key slide again, the key event slide, where we show that we started development in this in 2018. Well, what typically starts development of something? It's based upon the feedback that we get. So since the standards came out in 2016, every time someone goes through an application process and we gather feedback, or every time we meet someone at a sleep meeting and enjoy a wonderful conversation, we gather feedback. We had the 2 public comment periods. So once again, gathering feedback. And so all these changes that we're really doing here are really to address the feedback that we've gotten from our accredited programs. And it's to do these things: minimize redundancy, allow flexibility, account for shared relationships between programs and services, accommodate new or improved technologies, and this is a good one: consider the evolving roles of physicians, advanced practice providers, technical staff, and administrative support staff. So we know that roles are changing, and so this allows us to be able to make sure that we are making adjustments for these evolving roles too. And so when we get to the standards portion, there's a number of examples we'll talk through that really, once again, highlight these principles. So let's break it down a little bit more now. So we talked about there's really 2 differences, 2 areas where we're going to notice differences: the framework and the standards. So the framework is the structure of the application process, and the standards are the requirements that must be met. So framework, structure, standards, the requirements. So as we talk about the framework, I think we first need to introduce and make sure everybody understands accreditation networks, because remember that theme that we talked about between accreditation and membership, really aligning with networks. So even though we introduced this in 2021, we want to make sure that everyone understands what is a network. So a network is something we introduced in 2021 that allows us to begin grouping these programs or services that are operating in a manner where they're sharing policies and procedures, where they're sharing staff. And because of that, then from an application perspective, they're able to have an improved application process, right? Many might recall before accreditation networks where maybe they had to upload the same policy in a number of applications that they had, even though they were the same. Nothing really synced or shared or anything like that. Well, now in an application, we have what's considered network policies, where things apply to the network, so it reduces redundancy. We also align expiration dates and site visit schedules so that and someone going through an application process, especially if they're in a large network, they're not always constantly working on an accreditation application. Right? Maybe a site visitor may be coming out every year, depending on the number of programs they might have. But we align those expiration dates. We align those site visit schedules so that it can be a uniform process. And then once every 5 years, that network is kind of going through that accreditation process. And it incentivizes our networks through the use of volume pricing too. So understanding the fact that we have networks and that we introduce that, now we can begin to talk about the framework. And so currently right now, what we have is this infographic on the left. And what we have is program types, but within the program type, we have these services. So every sleep facility has to have these services. So a sleep clinic, in-lab testing, home sleep apnea testing. Independent sleep practice, they need to have a sleep clinic, and they need to have home sleep apnea test service. But what happens is, once again, it's very linear. So what it means is anytime someone wants to add a service, they have to add a whole new program, right? So, and then that program is really, from an application perspective, a representation of the lab. So instead of what our current model is, where we're moving to is where we're focusing on the services. So instead of picture on the left, the program types, we'll focus on the services and the relationships between those services. So that's what allows then for that flexibility, kind of that a la carte or that tailored system, that modular approach where we're able to move different things, add or remove specific services um, as it relates to their network. And so this infographic on the right helps represent that. So this is a small network, and we'll consider a small network maybe a single sleep facility. Right? Actually, if you are a single sleep facility, as indicated, there's probably very little impact that you may experience. Right? By the changes we're talking about here really begin to scale. So as the network continues to grow, then that's where we begin to see improved efficiencies. Right? So if we are a single sleep facility, probably will experience uh, little to no impact. But what this does help represent, though, is this infographic on the right, is you can see how we can begin to see that, look, a sleep facility or this small network actually consists of two locations. A location A, where diagnostic testing is done, and a location B, where the clinic patient management is done. And the relationship between the fact that this clinic provides the patient management for those patients that are being tested in location A, whether it be through the lab or through home sleep apnea testing. So as a small network, we can see how this representation is not anything significant change to now. But what it does do is it allows for future growth where they, as a small network, can now add specific services that they might want in the future. And so let's take a look at what that might look like. So here's a representation of a larger network where now we can begin to see, look, there's multiple locations, even spanning more than two. They have three different locations. They have a location A, a location B, and a location C. We can see location A actually has a full representation of services, where location B is just a sleep clinic, and location C is another lab. But now that we have identified the services, we can begin to identify the relationships. Okay? And we can say, hey, we can understand that actually the clinic out of location B provides the patient management for the patients that are being tested out of the lab in location C. But we can also see that there is maybe shared patient management being done from that clinic that's in location A. We can see that location B utilizes the same DME supplier that's found within the network. The same for the lab at location C. It also utilizes the same HSAT service location. So we can begin to understand how we now understand the full complexity of that network just by focusing on the services and then the relationships between the services. And so that's where then we begin to experience the more efficient application experience where they can just simply add or remove services without necessarily having to add an entire new program that one might currently have to do. So since we are moving to a service-based model, what that means is our fees also then have to align with that. And so our pricing chart was released recently, and you can find this on our new model webpage as well. And we have a link to that as well at the end of the presentation. But this is our pricing chart. And so there's a corresponding fee to the specific service. So we'll see that a sleep clinic is $500, HSAT diagnostic is $4,000, in-lab and HSAT diagnostic $4,500, and then a DME supplier $1,500. Now, how does that compare? Well, a current sleep facility right now is either paying $4,500 for new, or they would be paying $7,200 for reaccreditation. And then membership is involved in there. And so we'll talk about that in a little bit. But currently, it's $4,500 or $7,200. So a full service sleep center. And really what that means is the kind of exact same services that was needed underneath a sleep facility. Respectively, they would be paying $5,000. So an increase of what is $500 from that sleep facility. Independent sleep practice compared to the HSAT focus practice actually would be paying the same, $4,500. And then the DME supplier, when adding this onto a network, would be paying $1,500 compared to $2,000, so $500 less. So we want to make sure that we address this common question which is why did the full service sleep center increase $500? And so we want to make sure that we are transparent in this. But it's actually in two ways. The first is we're actually simplifying the accreditation fee structure. We talked about on the previous slide, okay, it's $4,500 for new or it's $7,200 for reaccred. Well, now there really will be no distinction between new accreditation or reaccreditation. So for all of those that may recall, okay, they become a member in order to be able to get the discount on the year that they expire. There's really no difference now between new accreditation or reaccreditation. There will simply be just an accreditation fee tied to that service. The second is inflation adjustment. So we do want to be transparent, indicate that the last adjustment to the accreditation fee was in 2012. And so when we consider inflation, what is a $4,500 fee in 2012 actually is equivalent to $6,249 today, which is actually higher than what would be $5,000. And so what that means is the ASM will still remain the most competitive per year fee structure due to what is the ASM's 5-year accreditation term. Because if we think through that, what we're saying is that for the course of 5 years, it's actually only increasing $100 per year. That puts us at what is $1,000 per year. And so that is very reasonable. Other reasons that are, or benefits that are ASM's pricing is now with this new model, you only have to pay for what you need. So you can add specific services that you need, and then the corresponding fee will be tied to that service. Once again, simplified renewal. So there's no distinction anymore between new or reaccreditation. It's just simply, this is the accreditation fee for the service that we're applying for. And we will still continue to maintain our volume pricing discounts based on the services. So with that said, what we're going to do now is we're going to focus on the second part of where we'll see the changes, which is the standards for accreditation. So remember, the standards are the requirements that must be met. So when we think about a sleep facility kind of operating underneath this new model, actually what we're going to see is most of the standards end up remaining the same. Really what the standards are doing is aligning with, once again, the framework and that of the networks. And so our sleep facility ISP and DME standards, those are actually getting merged into what is a single standards for accreditation, in which there is a network section, meaning it's the responsibility of the network in order to meet these standards. There is a site section, so it's the responsibility of a physical site. We can think of things of like the address, meaning they have to have a designated address, and then responsibilities for the sleep clinic, the lab, HSAT, and DME. Now, I want to reiterate this point here because as we begin to talk about the standards, remember the standards were reviewed with the intent to remove barriers, not add burden, as long as they did not affect high quality care of the standards. And so once again, if we think about a sleep facility operating now compared to how a sleep facility would operate in effective 2025, they would either see the same type of compliance, right? Because most of the standards remain the same, or they would see increased compliance, meaning simplified compliance, because the standards were looked at with the intent to remove barriers. So I do have some examples here that we'll talk through that helps represent those changes. The first one is the facility director. So right now, currently, we require a facility director to oversee the entire accredited program. Well, one of the feedbacks that we got was, look, we would like to be able to appoint 2 individuals to serve in that role, right? As networks continue to grow and grow, then that would mean that there might need to be some shared responsibilities there. And so that's what the 2025 standards have done, is we have improved access by allowing there to be a network director and a site director. So the network director is responsible for things such as quality assurance, process and policy, safety-related issues, where that site director is responsible for things such as qualifications and training of staff, oversight of equipment. So things that you might find specifically at a site. Now, we talk about the fact that there's not increased or an additional impact for, say, smaller programs. And so if we do not have two individuals to serve in either the net director or site director role, then you can appoint the same individual to serve in these roles. And actually, from a committee's perspective, when when the standards was recategorized into the network director and site director responsibilities, there was not any really thing additional that was added there. It was just a restructuring of current facility director requirements into what is the network director and site director. So once again, if you are and have the same individual fulfilling this role, they would not really experience any additional responsibilities. And so really this is a way to improve access for these larger networks that are looking to be able to utilize and appoint two different individuals. The second is our registered technical staff members. So currently right now, there is a principal registered technical staff member, and this individual is required to be present at the lab this number of operating hours. And so the requirements of this number of operating hours actually doesn't really change. But what has changed is this aspect where we say in the 2025 standards, the principal technologist can be present virtually or in person. So now this individual can fulfill their operating hour requirement virtually or in person. So really just trying to improve access here, especially as we know last year there was the sleep tech shortage presidential committee that was convened, and this was one of the areas in which they felt could improve access. Also, when the committee was discussing this, we thought about different scenarios in rural areas or territories where the use of this person virtually might come in handy as well. So improving access in these areas. Direct referrals. So currently right now for patients directly referred, the facility director or appropriately licensed medical staff member needs to review this information and make sure that it's in accordance with and make sure the test is appropriate, in accordance with their patient acceptance policy. Well, the 2025 standards for patients directly referred, a medical staff member or appropriately trained technical or administrative support staff member must review the information and make sure that it's in accordance to the service location's patient acceptance policy. So as we can think about the evolving roles here of what would be maybe technical or more administrative support staff members, committees take on this and then approved by the board is if we have patient acceptance policy, which receives oversight by the network director, site director, and they are appropriately trained, so oversight by the network director, site director, then what that means is that an appropriately trained technical or administrative support staff member may now review that information and determine if it's in accordance with that patient acceptance policy. So once again, improving access for what is that evolving role. Quality assurance. So this is one that we hinted to a little earlier. We do know that, yes, quality assurance can be one of those areas that might be a barrier. Well, simply by categorizing it now as a network standard, it now means that the network can meet compliance for the quality assurance program. So they are able to report on a single quality assurance program. And so simply just by recategorizing it, begins to, once again, simplify compliance. Inter-score reliability. So this is a very similar principle as the one before, quality assurance, where inter-score reliability, by conducting inter-score reliability as part of quality assurance, it is now categorized as a network standard. And so what that means is, once again, the network will be able to have a single inter-score reliability program. And then the last example we're going to share here is the last key standard I thought would be this aspect of diagnosis versus interpretation. So currently right now we focus on the diagnosis. And so what we say right now is the diagnosis needs to either be made by or reviewed by an individual who's board certified in sleep medicine. Well, the 2025 standards actually is shifting from the diagnosis to the sleep study interpretation, where we're defining those requirements. So what we say is an individual board certified in sleep medicine must either perform the sleep study interpretation or review the sleep study interpretation, but then is silent in the other aspect as relates to diagnosis. And so really actually what's occurring here is it's moving the board certified sleep specialist earlier into the equation in the patient workflow, where we're saying that at the interpretation, that's where we want the interpretation to either be made by someone who's board certified in sleep medicine or to review the sleep study interpretation. Because if we think through, once again, improving access, evolving roles, in some states, advanced practice providers may be able to make a diagnosis. And so now, after they make a diagnosis, based upon the interpretation of someone's board certified in sleep medicine, or at least been reviewed, then now their diagnosis no longer needs to be reviewed. So improving access. So if we begin to summarize then the differences and the standards and the frameworks, we can begin to see that all of these changes, once again, really is to improve the experience and based upon the feedback of our accredited programs. So the framework, which is the structure of the application process, that's going to be more streamlined and be more efficient to fit more practice models currently, but then that also sets our practices up for success to continue to evolve. And then from a standard perspective, which are the requirements that must be met, these is going to align with that of the networks, and it's also going to reflect current practices and technology, thereby reducing barriers. So simplifying compliance. So collectively, all of these changes, once again, really is to improve that experience, and we'll be able to experience a lot of improved benefits, whether it's a reduction or simplified compliance or an improved application process. So before I turn it over to Miriam, this is a slide that helps or guide you to the appropriate resources. So we do have a whole page dedicated to this new era of AASM accreditation, where we talk about the overview, the pricing charts, the FAQs. That's where our standards are at, along with the standards for accreditation. So I really do recommend taking a look at that one, because that principle of removing barriers affected a number of standards. And so I recommend taking a look at all of the standards to which barriers were removed, and you can find that on our website. And then our accreditation process and policies, which go into effect to align with that of the framework, also is on that as well. So with that being said, what I'm going to do is turn it over to Miriam now, who will talk about membership and how that's aligning with that of the network.
Thank you, Ray. Hello, everyone. My name is Miriam Owodele, and over the next few slides, I'll be covering what is happening with the current AASM facility membership. So we talk about why there's a change. Of course, we want to make sure that we align with the new model of accreditation being service-based, but also looking at the benefits that we currently offer, we wanted to make sure that we streamline them and add value for the entire network. Looking at what's changing, I'll be covering this in the next few slides, but we're changing the name. So currently it's called facility membership. We will be changing the name to network membership. And then we're offering some new and some enhanced benefits starting in 2025. And then we'll be talking about pricing. So you'll see that we're offering some new modular-based pricing that I will cover in the next coming slides. So what are these new benefits that we're talking about? I'll cover resources first, and these show some of the resources that help you stay competitive. So you'll see a priority listing on sleepeducation.org. This is an enhanced benefit. Currently, all facility members are listed on sleepeducation.org, but coming 2025, new members will be listed. We'll be giving a priority listing, which means that they'll get a badge showing that they are a member and that they will be listed higher on the website than non-members, which we think is a great benefit. The site currently gets 1.3 million page views per year, so it's a great way to make sure that your center, your location is receiving some visibility. The next benefit, which is new, I'm not, sorry, Ray, go back one. Is access to a sleep medicine compensation survey dashboard. And this will help you make better decisions about salaries and pay for yourself and for your staff. You'll get access to free personalization on patient education brochures, which means that you can put your logo, your site location on these brochures, and it just makes sure that patients have your information at hand. Access to maintenance of accreditation, which allows you to make continuous improvements in your accreditation application over the course of your accreditation application. And then coding and compliance support. So if you have any billing issues, AASM staff is on hand to help you address those issues and answer pressing questions that you may have. And then a media relations toolkit. And this is something that helps you make sure that your name is out there, gives you tools on how to deal with the press, and it gives you templates as well. So it's a great resource that we hope that you will all use. In 2025, there will be some benefits that are transitioning away, which include the access to the scoring manual and ASEP Essentials, and that will be coming to an end on December 31st. Okay, next slide, please. In terms of discounts, which we think is the biggest change that we are offering, and it helps you do business better, there will be a 75% discount on job postings in the Career Center. And so that's saving you about $300 on a 30-day job posting. There will be a 30% discount on sleep ISR subscriptions, which is bigger than what we offered before, saving you up to $990 a year. A 30% discount on A-Step modules, which is a training program that gives your new techs incoming up to 26 CEC credits upon completion. There's a $500 discount on A-Step provider accreditation and reaccreditation fees. And the biggest benefit that we see is a $100 membership discount for your staff, which allows them to become AS individual members at a substantial discount of $140. So that's a great benefit that we wanted to make sure that we told you guys about. Next slide, please. So looking into membership pricing. So as we said, aligning with the new service-based accreditation, the fees will be based on the number of services in your network. And what does that mean? As Ray said, for a full service sleep center, the cost will now be $1,200. So that is someone who has 3 services. You have a lab, a clinic, and an HSAT. Your cost will be $1,200 versus an HSAT focused, which will be $800 per year. You can always add on additional services within your network for an additional $400, and your membership fee will be billed annually to your network billing contact. So now I'll walk you through an example of what that invoice will look like. You can go to the next slide, right? So here is an example for a smaller network example. So you'll see that we list the locations and their addresses and how many services are within each network. And then you'll see the total next to it. And so for those with larger complex networks, we'll have a listing of all the locations within your network so that you have a full view of what you offer and what's in your network with the total fee. So we're making it easier. We're making it very transparent for you to see how many services you have. And you'll see more about this in your invoice that will be coming out in October. Next slide, please. So what's changing? 2025, you'll see a network invoice coming mid-October. So look forward to that. And like I said, you'll see an itemized view of all the services within your network with pricing. If you have any questions, the membership team is always here to help you address them. You'll notice that your company admins, when you log into the AASM platform, will have a new portal view allowing you to see your invoice, to see all the networks within your service or all the services within your network. And then just a reminder that network benefits will take effect in January 2025. So we're very excited about the changes. And we are here to help you address because we know that these changes are a lot. So we're always here to help you address those questions that you may have.
Okay, so it looks like we have two open questions. The first one is, what is the definition of a network? Do they need to share staff? So yes, there are some definitions for what is a network, and sharing of staff is one of them. So you need to be able to operate underneath the same policy and procedures, and share staff is a part of what is that network definition. Okay. There's a sub question to that, which is, do you perform multiple site visits? Um, Interesting question. I feel like there's a lot of actually clarifying questions I need to be able to address that one. What I'll say is that each network, anytime someone is going through an accreditation application, especially if it is with a service that is HSAT or a lab, it does require a site visit. Okay, and then depending upon the type of service would determine whether it's an in-person or virtual site visit. Now, when what we try to do is combine those site visits, like we said, right? So that they're on the same schedules. So what that means is when the network goes through the accreditation application process, then the network as a whole is receiving a uniformed or a single site visit. That's what allows us to make sure that it's an efficient process, both for you, but for us as well. Second question from Marietta Bibbs. How does the diagnosis interpretation change comply with CMS standards? Well, hello, Marietta. Second is, actually, I think that is something you'd probably want to check with your payer requirements. So I'm going to direct you to check that because accreditation is just one of the payer requirements. And so receiving accreditation is what checks off that box. But there's a number of payer requirements. So I direct you to that, or you could possibly email coding@aasm.org. This third question here is, will there be invoiced fees in fall 2024, even if reaccreditation is not due at that time? So I think that's going to be a membership question, Miriam. I think that's what it's asked for.
Great. So if you are a member now, regardless of when your reaccreditation is, you will receive an invoice. But at the time of reaccreditation, you might lose some access to your benefits unless you renew. I hope that's addressing the question you have.
Okay, next question. We just completed. It looks like they took away the question I was reading. It must have been addressed. Okay, when you speak on being an appropriately licensed medical staff member to review the H&Ps for direct referrals, would this be your network director or site director now too? Yeah, so it's network director, site director. They're still going to qualify because they're what's going to fall underneath what will be the medical staff members. When we talk about that standard related to how there's improved access for. What we're talking about specifically there is improved access for allowing appropriately trained technical staff or administrative support staff members. Medical staff members would still be able to fall on that, especially what would be the network director and site director. Next question, will you have a new reference manual to purchase reflecting these changes? Yes, so we are currently in the process of updating our new reference manual. And we are anticipating that coming out Q4 of this year. And so definitely effective January 2025, there will be a new reference manual, which will be updated to reflect the standards, but then also from a framework perspective, it also needed to be updated to align with our new model of accreditation too. Okay, next one. How does the payment structure look for a sleep lab that does testing and HSAT, but does not have a clinic? Does QA need to be done for all referring providers? Do their clinics need to be listed under sleep lab membership? What I would actually say to that is, just like currently, there has to be a clinic involved. There has to be patient management anytime there is testing involved. So I would say that kind of an independent lab still must have some patients being managed by a sleep clinic, just like it does now. So a sleep facility is made up of, yes, a lab, but it requires HSAT and a clinic, and then a independent sleep practice, which is a practice, sleep practice, so a sleep clinic in which they're doing HSATs. And so there does have to be that involvement from a clinic. And so that's one of the minimum requirements that's in place now, but will continue to be in place in our new model standards. I see there's a number here, Miriam, about scoring manual and what that'll look like as a member benefit. Maybe you could touch base on that.
Right. So I know that I briefly touched over that. So we are making that an individual benefit. So currently, all individual members receive free scoring manual access, which is why we are keeping that discount for your team members, for your staff, to become individual members. So we're encouraging everyone to become individual members because this will no longer be a benefit that you can pass on to your staff.
So it looks like we're wrapping up towards the end of some of these, which is, does scoring for other networked locations qualify as shared staffing? If you're referencing the InterScore reliability program here, so it is a network standard. Okay, and so what that means is the network, if you are staff and you are shared staff, well then the assumption here would be that you are shared staff within a network. All right, so therefore you can report for that individual in your InterScore reliability program singularly, regardless of where they work at different locations, but within the network. All right. Now, if they are in spanning across multiple networks, well, then that's different. But if you are sharing staff within a network, then that means you're able to report on that individual for that network. There is one question here. We have 4 clinic locations and 2 labs. Do we pay $500 per clinic location, even if the clinic is held there only 1 day a week? So to answer that, I think that's actually a good question. And the way that it works is that each service has its corresponding fee. Okay, so if you were to apply for all 4 of those sleep clinic locations to obtain accreditation, then yes, there would be a $500 fee associated to each of those. Now, a question might be is whether or not you want to pursue accreditation for each of those 4 clinics. So now that would be something that you would want to determine. But ideally, yes, if you're pursuing them, and then there is a $500 fee associated for each of those clinics. Okay, I'm skimming through most of these, Miriam, and it looks like we've covered most of them. Are you seeing any you think we need to address? I see
one
one.
from Suzanne Pearson.
Okay, can you read that one out for me?
In May of 2025, we're restructuring and our hospital sleep lab staff we will do HSATs and in-labs at the hospital, and we will distribute HSATs in 4 separate clinic locations. We don't share staff, but we all work together. I'm confused by the requirement to share staff. She says we're all employed by the same health system. I think that is what is meant by share staff. The staff doesn't cross from lab to clinic.
Yeah, so think of almost sharing of staff as like a pool. Okay, it's a pool. And so you have all of the staff that work within your health system kind of in this pool. And then you can assign, if needed, to where these staff are working for those specific locations. But when we're talking about sharing of staff, we have to think about the application experience, right? We don't want to have to upload all the CMEs for all of these staff multiple times. And so that's why we ultimately think of the staff as a pool, which we're uploading information for them individually, and then at which point in time we can then assign them. Okay.
I just wanted to address again, yes, the recording will be made available after this, probably in another week or 2. So yes, the recording will be made available. Someone asked if they could get a copy of the chat Q&A. Ray, maybe what we'll do is we'll have these common questions addressed on the website somewhere. So you'll have access to them.
Yeah, I think that's a great idea. So we'll take a look at these, prepare certain FAQs, and then post them to our website based upon the questions that we get. going to take one more quick scan just to make sure that there's no underlying question that would be worth.
I see one question about membership pricing per location. It is by service, and so you have to have accreditation, obviously, to be able to become a member. And you can add on services. So if you have 3 different services, a lab, a clinic, and HSAT, all 3 of those would need to get membership for $400, which would make 12. I think we've just all.
Okay. Yeah, I think so too. I will say that there's 1 or 2 questions in here that's really trying to get more specific to your sleep facility or to your network. And actually, what I'm going to recommend is please, to address that question specifically for you, if you could email that question to us either at accreditation@asm.org, or if it's a membership one, to membership@asm.org. Also, our personal emails are here as well. So Ray Antonez or Miriam. So if it's something specific that's related to your network, to best address that question for you, if you could please email us for that. Okay, and then we'll follow up, or we'll have one of our team members follow up to be able to address that. Okay, so with that being said, then I think what we'll do is wrap up this webinar because we are just 2 minutes to the hour. And so I would like to thank everybody for joining this webinar on updates to AASM accreditation. I'd like to thank Dr. Olson for coming and being a part of this webinar and providing those wonderful introductory comments. There's a lot of exciting changes. We talk about the fact that everything that we're really doing here is to benefit our accredited programs and is from the feedback that you have provided us. So a lot of exciting changes that are just right around the corner. Thank you very much, everyone, for joining. And if you have any questions, please touch base with us by emailing us. Thank you.